I'm sure you saw him.
How long has he been on the ship?
That one he just started in May
Okay.
to
Yeah,
do
that one
rotations.
that one was called I think the Brilliant Lady was
Yep,
the name.
that's,
Okay.
that's the
Yep.
one he's on.
Bingo.
Wow.
Yep.
Yeah,
Small world.
yeah.
Yeah. Cool. So did you have your workshop or it's this week?
It's this Saturday. Yeah,
Okay. You
yeah.
all set?
Yeah, I did have one question about, I know with the neuropathy, we kind of plan for about 16 sessions, right? Um, if I'm treating sciatica, do I do about the same number of sessions? Would I plan for that or less?
I would anticipate much less. I would probably sell 8.
Yeah, yeah, that's what I was kind of thinking. Yeah, we'll see. See if my voice can hold up.
Yeah.
You
And then just
you should
and then
definitely
just set it up for them.
do vagal stimulation on yourself for your voice. It'll work.
Oh, I hadn't thought about that.
It
Okay,
works. I've done it many times.
okay.
It works.
Yeah, tea can only do so much.
How many people are registered for the workshop?
I have 13 in the morning and 8 in the afternoon. So
That's
two.
great. And you're going to demonstrate on as many of them as you can?
Absolutely. Yeah.
Great. Yep. Just ask them which leg is worse and let them experience it and let them hold it. So everybody sees they're holding it, their foot's doing this, they got a smile on their face. That's what really plants the seed when you tell them, hey, you can come in twice a week for 8 weeks to do it here, and feel free to do you can say, 3 of you guys can take one of our stim pods home with you for 6 weeks, and we'll figure that part out, get
Okay.
some people and tell them, I've only got 3 units that I can send for home use, so that the whole scarcity bit comes into play. And I think it should work out really well for you. How many of these people are existing patients versus brand new people that you've never met before?
Um, about a quarter of them are brand new, and the others are people in my world, but not heavy in my world. They're
Okay.
just in and out.
What
So,
what
And Michelle, definitely pick out whoever the biggest peacock or the loudest person in the room and do it to them first and then make them speak.
okay.
what kind of work do you do? Are
I'm
you
a
a chiropractor or
physical therapist.
okay?
Yeah. I'm not sure how to also incorporate the red light. I know the CareWare red light can also be incorporated with it, but I don't know how to incorporate it with the Stimpod.
It's very easy. If you're given the CareWare for home, you can put it at the posterior tibial nerve behind the knee. And you can put it on the common peroneal right at the fibular head and just have them wear it.
So you do the 30 minutes on the one point and 30 minutes on the other point?
Yeah, it's a wearable and they do it as you tell them to. It's
Okay.
just it's 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 a good idea.
Okay. So basically at the same point that I'm putting the broom.
Yep,
Okay.
easy.
Where do you get that red light?
So
I get
that
it through CareWare.
Yeah, I'll send you a link
Okay,
to Donna's website.
It's a
okay.
great unit. I use it a lot for other things. I just haven't used it for
Yeah, that'd be
neuropathy.
perfect. Thank you.
Hey, everyone, I'm Jill, Dr. Jill.
Okay.
Question, can you repeat what you said about putting the red light on after the stim pod?
she's talking about this thing that's called CareWare. It's like a DME. It's something you give your patients to take home, and it's a small unit, and we're just putting it at the same points that we're treating. common peroneal and posterior tibial. And I don't have it, but Michelle, what do you use CareWare for besides? What do you use it for predominantly?
I use it for plantar fasciitis and knee or hip pain.
All right. And how much do you rent it for?
$50 a week.
All right.
How much do they cost?
My I can sell a unit for
Okay.
$495, but I only pay 60% of that.
Okay.
They give us a 40% discount. And then you have to buy the patches too. So
But those last
it's
pretty long. I think it's like 25 usage, like a
40
month.
something. Yeah, 40
40.
some uses. So it's a pretty good little money maker.
Mary Jane, I just sent you Donna's the sales rep. I just sent you her contact info.
Okay.
You can reach
Perfect.
out to her.
Perfect. Thank you.
Yep.
Can you send that to me too, Sam?
Sure.
Thank you.
What's happening, Angie?
I had a patient that I treated with tinnitus that at Kieran's recommendations, and she has sensory neural hearing loss. She reached out and wanted to come back in for another treatment. She really liked, I mean, she's not sure if the tinnitus is she's accommodating or if it's reducing, but sh her overall body, like nervous system, she felt better with it. So she goes back to the audiologist in ENT next week, and then will possibly come back for a third treatment the week after. So she came once last week, once this week, and she'll probably come after next week for a third treatment. And it's her right ear hearing loss and tinnitus. So I did left, I wasn't sure which ear to treat, but I just did both ears. So I did left tragus, left mastoid, lateral to the left eye, above the eye here. And then I did the tragus on the right, the mastoid on the right, above the eyebrow, and lateral to the eye. And then in front, right in front of the ear. And then I did 5 minutes on the left ear symboconcha. So, and a lot of explanation of the anatomy to her and why it can be so randomly unique for everyone. And so, um, so she was appreciative of the anatomy and how it can be so varied on why people get tinnitus, and where you place the probe can be different for everyone, but some people can get really great results. Sometimes it's 50-50. So I was just kind of like managing her expectations on why it can take some time. And then she had questions about research and is there a database of research? I said, no. So it's like, how many people do tinnitus? There's not like a massive volume of tinnitus that goes to any one clinic, so it was a lot of like just discussion and explanation of stuff.
I'd be like,
So-
we're trying it. Nothing else works. It's not going to hurt you.
Yeah,
Yes.
exactly.
That's
It's
it.
like, yeah, like I know this has worked really well for some clinicians and some it hasn't. And so that's the situation.
That's what I would say.
Yeah. So I think getting the honest answers and just kind of being as transparent as possible has helped. She admits she's not neurodivergent, so she's like on the anxious side generally, and just kind of in grief mode because this was a sudden loss of hearing after dropping something into a glass bowl. Um, it's just sudden significant hearing loss and then tinnitus, and nobody has anything to offer unless she wants to get a cochlear implant, which she does not want. So it's kind of sad because she's just like, all she did was drop something into a glass bowl and it made a big clang, and then she heard a pop, and then she lost her hearing, and now she had vertigo attack and got that addressed, and now she's got hearing lost and the ringing. So she's my case that I'm like, well, if you want to come back, and we'll just keep trying, but she likes the vagus nerve part of it, so that's
Yeah, the
helping.
vagal should be great for her. And
Yeah.
she'd be one as well, to rent her one of your stim pods so that she can do vagal stim twice a day at home. That's where I think for a week or two, she may see some profound improvements in her mood, reducing her anxiety. That could
Yeah.
be a really good, next step for you to consider as well.
I did introduce it today and just say, it's just an idea because she drives an hour to come here. And
Okay.
so I said, just think about it. Maybe over the next treatment or two, you find that might be a good cocktail of locations. And then this is something you do daily, twice daily, and then the face ear treatment every other day. And,
Yep.
so we'll see. So that's kind of my challenge patient right now.
Good.
But I'm glad she came back. Something's helping.
Yep. Great. What's happening in the Bay Area, Kim?
No idea.
Oh, I've been doing I've been using Stimpod on some of my patients, and yeah, I do have a couple questions. So I was listening to the recording because I couldn't come last week and I think Kieran, you said something about that you're aggressive with the start of it, and you start at 2.0. And is that just with people with neuropathy, or
Yeah.
what are you? Okay.
So like Kim, if somebody appears to be healthy, I'm definitely not starting at 2.
Okay.
If you're looking at like a decrepit person coming barely ambulatory, I'm just gonna start at 2 and just go as fast as I can go. And if they're a healthy, fresh looking person, not completely broken by the world, start at 1.
Is that just for neuropathy, or is that for anything?
That's for anything.
Okay. Okay. So that's one of my questions. And then
Other than vagal stimulation, I would never start at 0.2 on anybody.
right. Okay. Okay. But so for those people, are you trying to get to a higher than a tapping, or are you just starting at a higher
No,
point
no,
to get to the
no,
top?
because I know
Okay.
that they're gonna be tapping forever.
Okay.
Like
So you know it's going to
say
take more to get there.
like just imagine you have a patient that comes in with like thenar atrophy, right? And you're like, all right, we're gonna treat the ulnar nerve. This thing is gonna be so dead to get it anywhere. Like, why waste the time? Because I know that I'm gonna go to 0.1 and 30, and then I'm gonna have to go to 0.2. You know what I mean? You're just looking at them and just use your professional ability to assess a patient, and that's it.
Okay. So there's no risk of people feeling like they're getting shocked and like jumping if you do that.
I mean, you can do it any way you want. I'm just it's like you can go as slow as you want, but always get up to that point that you're always going to try to get to that uncomfortable point
Yeah.
and
Okay.
then back it off. So like
Yeah.
imagine you have a patient who comes in, he's 280 pounds, barely ambulatory, diabetic. Like, what do you expect this guy's condition is going to be? It's not going to be good. Nothing's going to be good, right? And you know you're going to get to 0.2. You've had enough experience with this. You know you're going to 0.2. So
Yeah.
I'm just assessing people for what they are, and then just moving it along quicker, just to keep things moving.
Yeah, and keep in mind it's just math. Okay, so the only difference between point one and point two, when you're on point two, you're just counting by twos.
Yeah.
So if you were to be at point two and one MA, okay, well, you're not shocking anybody. That's just like being at point one and two MA. So if you do start at point two and you start low, you're just counting by twos. Once you get up to 15 at point two, that's where you would have left off at 30 at point one. Okay, so it's the same thing. It's just when you get above 15 at point 2, now you've got more power than you would have maxed out with at point 1.
Yeah, okay. My other question that I have is for femoral nerve. So I've been trying to treat some of my patients with pelvic floor issues, femoral nerve, and a lot of times they'll say they feel it running down the leg, but am I trying to get them to feel it also more closer to the groin? Am I trying to move it? Because if I move it a little bit, they will feel it there, but I'm not sure if I'm what I should be
Like
focusing on.
femoral goes down the anterior thigh,
Yeah.
right? Because you can pick it up, it'll go towards the groin. If you go more medial, if you go more lateral, it's going to go in the lateral thigh also. I want them feeling it running down down the front of their leg.
Oh, so you want it to feel straight down the leg, not veering towards the inner thigh
No,
for pelvic floor. Okay, that's what I wasn't
no.
sure about. Okay.
So is that sensory, Kieran? Like a sensory, like
Yes.
sensation and not necessarily
Yeah, it's
motor?
you're
Okay.
not looking at motor. You're just I want you to feel this running down the front of your anterior thigh. So Kim, what are your results with your pelvic floor people?
Um, I mean, I think they have felt like they've gotten a little bit of release, but I wasn't sure. I've been kind of fiddling with trying to get it more to the medial because I was thinking that they should be feeling it a little bit more towards the pelvic floor. So I probably wasn't getting the best results if my goal is to get just really focus on femoral nerve because I get them feeling it down the front of their thigh, but then I always try to veer medial. So I'm probably not getting the best results if you're saying that.
I mean, if you're doing posterior tibial and femoral and that ground pad's on S3, you're going to get enough therapy to the pelvic floor.
Okay, so I should do both femoral and posterior tib.
I would, yeah. And if you want
Okay.
to do if you want to do if you want to do 3, 3, 3, and 3, you're
Yeah.
on for 12 minutes versus 10. That's it.
I have a question along the same lines for urinary incontinence. Um, so if the pad is on the top of the butt crack and the probe is on the groin, you want, like my one patient, she's pretty sensitive, so I just keep it where she can tolerate the pen in stimulation at the pen and not try to ramp it up so she feels it down the thigh because it gets too intense. So is that okay? It is where you just,
I
I
mean,
don't know if
like,
it's going down the thigh though, but it's like I hope I'm on it, but I feel for the femoral artery kind of and just be in that middle inguinal ligament
like
area and
to be honest with you, I didn't do femoral for the longest time. And I just
okay.
did posterior tibial and I tortured my patients. I was like, I'm turning this up as much as you can handle it, 5 minutes on each, because I want this to stop. Like, because the therapy's coming through that ground pad. So I want to blast that
Okay.
ground pad as much as you can tolerate. Um,
Glenn,
and,
you can
and you feel it like, I don't know if you've ever done it to yourself, but you feel it going all around your sacrum. It's a wild feeling.
can you find the same pad with the little butt? I think in one of the drawers over there, I have like a little holder that has all these pads in it.
I don't know who's talking. I can't see what
Yeah.
you're talking about.
Yeah,
Sorry,
Okay.
sorry.
that's right.
Okay, well, yeah, I think I did 5 minutes on the posterior tib on the left, and then I did it on the femoral because she's got a lot of ankle hardware on the right.
Okay.
So I was, well, let's try the femoral, and then maybe next time we can do the back of the knee next time on the right because
Yeah,
that should work too, right?
that's good thinking, Angie. But
Okay.
I literally tell them I'm going to turn this up as much as you can tolerate. I don't care if it's really pinching because we just want this to end.
Okay.
You know, like
Yeah.
if you want to like keep them around forever, do it low. You
Yeah.
know,
Mhm.
but
Okay. Yeah. All right. Thanks. Yeah.
I'm all excited. I got my new pad for my PEMF unit that we're going to start doing. I'm going to do a talk, and then we're going to do pelvic floor with that also. And going to be doing stuff for ED, but instead of spending $60,000 on a gazelle chair for pelvic floor, which is the exact same PEMF that I'm using, it was nothing. So I'm excited to use it.
Actually, if you put that in the back seat of the Jeep when you're driving the guys up to Vermont over the
They're
weekend,
16 years old. I don't need their pelvic floor to be any more strong. And they're going to be having hard-ons anyway, so it's no, I'm good.
Are
Staying
you
being a
going?
little evil. Going to Vermont, take my son to do country stuff.
Are you going on the same trip as you did last year or different?
The same trip, different boys, same trip,
Different friend?
different friends. Yeah.
Yeah, okay.
I have a
Hopefully they don't.
win. I got my first adult customer for the 6 week, so I'm happy about that.
right?
She's using it for weakness in her ankle that's interfering with her horseback riding. So I taught her the common perineal and the posterior tib and vagus. She like got caught on really quickly. So
So,
she's
so,
doing that at home.
so horseback riders have a lot of inversion in their ankle, and you got to think about all that stuff as a result of the stirrups.
Okay. Yeah, she has problems. She has limits in plantar flexion and dorsiflexion. But I did one treatment with her and she was like, she felt an immediate improvement. She was pretty amazed. So she was like bought in after the first session. So she's coming in for hands-on treatment next week, so I'll be able to kind of touch base with her too and tell her
And
how
you
she
could
can.
sell horse people anything. You could sell horse people anything.
Okay,
I
that's good.
agree. I agree. I am a horse person. They'll do whatever it takes.
And golfers. Same thing with golfers.
Okay.
They will buy into anything they think might help their golf game.
So yeah, she's been riding since she was 6 and she's like 43 now. And so she wants to make sure she keeps riding and, you know, control
She
the horse.
will. Yep, she
Yeah.
will.
She's neat, really neat lady. Um,
Um, I have a question.
Sure.
Um, so I guess at our clinic, we're not really like setting aside dedicated sessions for people to use Stimpod. We're just incorporating them when we can into the session. And then if you know our clinic is relatively busy and we're not typically able to get most people
Which clinic are you
in
with,
multiple
Jacqueline?
times a week, I mean, would you still expect Taylor and Thornburg PT in
Okay.
California? Yeah.
Good.
And so, would you still expect to see a benefit if, say, like you could only use it with somebody once a week? And like if we didn't have time to do the vagal stim, if we're just doing the stim pod.
So if you're treating
uh,
PT wise, Stimpod works great for pain all the time.
Yeah, like if you don't have time to do the vagal stim, if you're just doing the like 3 to 5 minutes for the nerve that's, the along the pathway of where the pain is, you could still get some
Yeah, great.
effects. Yeah. And
Totally.
then would you expect if you're just doing it like once a week, would you still that would be enough if you didn't do the vagal stim, you just did the 3 to 5 minutes?
I mean, you do what you can do, obviously, and if you're
Yeah.
not separating it, it is what it is. So it's going to
Yeah.
offer them pain relief after you do it. And it's hugely beneficial for PT in the post-surgical setting to get them moving and treating that post-surgical pain. And
Okay.
if like you're going to offer them pain relief, they're going to actually come in more post-surgically because you don't need drugs for the most part. If you do it properly, they're going to get up and move in rehab immediately without pain.
I mean, there's been a couple patients that I have tried it with, and I don't know if I haven't tried it enough with them or I haven't put it in the right spots, but it hasn't seemed like it's made a difference pain-wise. So with one of my patients who's got this like really, um, I guess it's just like this intractable pain that won't seem to go away from just like it just seems like a lumbar radiculopathy. I mean, I've done screening and it doesn't seem like there's peripheral nerve involvement. It doesn't seem like there's SI joint involvement. It seems like it's just a lumbar radiculopathy, and it is just like nothing is helping. She's had like everything, like she's had steroid injections and she's done her PT and we've tried the Stimpod and she's kind of tried everything. She's even doing like acupuncture and all these other things, and it's just nothing is really helping for her. So I don't know if it's, she has only been able to come in at most once every 1 or 2 weeks just because our schedule is really full. So I have tried it with her, and I don't know if it's just she's not coming in frequently enough or we're not doing it enough for her to get a benefit from it. Um,
Well, what did you treat with this lady? And what was her pain
um,
distribution?
it seemed like it was like a radiculopathy of like L5, like the posterior lateral, like uh
So
leg.
if you're just so if you're you have to try to replicate the pain pattern with her
Okay.
and make sure you turn it up all the way on
Okay.
her. Like make sure you also differentiate between a tap and a pinch because the first time they feel it, they're gonna be freaked out. And then you're a newbie, so you don't know what you're doing. Be like, oh, all right. Be like, I'm like, no, 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 that's a tap. I'm going to
Okay.
show you what a pinch is. We're going to turn it up to a pinch, and then you're going to tell me because I'm sure you weren't on it, and I'm sure you didn't get it high enough.
Okay.
So like, just use it on yourself. Use it in the staff on just so you can learn how to use
Yeah,
it and
yeah. I've
how
used it
much you
on
have.
myself, and I guess I'm not sure if it feels different to somebody who's in pain, because I mean, I don't have pain. So I mean, I can feel it, I can turn it up and I can feel it. Um, and I guess I don't know, like just as high as she can tolerate it. I mean, she seems pretty okay. She's not a super jumpy or fearful person. Um, just
And where are you putting the probe and where are you putting the pad?
I put it at the posterior tibial nerve, and then I put the ground pad on her foot, on the front of her foot.
All right, so that doesn't make sense. Number one,
Oh, I'm sorry.
like no, I'm not. I'm just telling you. So if you're treating posterior tibial, put it underneath because it runs underneath your foot. Put it
Okay.
underneath the toes. Like
Okay.
the only time you're going to treat on the top of the toes is the dorsolateral cutaneous nerve, which is in the middle of your
Okay.
shin. But you wanted to replicate what she was actually feeling,
Yeah.
and so you were nowhere near it, were you? Like so, like if
Well,
I'm treating her,
uh-huh.
I'm like, we're going to replicate what you have. Break out your essential anatomy app and hunt and peck until you find it. And
I
then
mean,
you're going to find it.
she said she could feel it in her leg. I mean, it wasn't
No,
necessarily
I
like
understand that.
yeah.
No, but I would be like, Jacqueline, I'm going to replicate your pain. All right.
Okay.
We're going to find this nerve and we're going to replicate it. And we're going to put this on this because this changes the function of the nerve. So if the nerve's expressing pain, it's going to make it as normal as it can be on this one
Okay.
visit. So I'm going to hunt and peck until we find this. And you're going to learn how to do it. Do it on yourself. If you're saying it's running down the lateral side of her thigh, I would go off of the iliac crest and
Okay.
find it till it's running down the lateral side of your thigh.
Okay.
And that's just experience. You'll get it.
Okay.
You just have to learn basic. The skin is actually going on top of the iliac crest and finding it there. If it's replicating, if so, literally give her the essential anatomy app
Okay.
and say, pick out what hurts, right? And then
Okay.
she'll give it back to you. And now she told you what it is. And you're like, all right, I'm going to replicate that. And you go find that
Okay.
because like words are different than what people are actually feeling in reality. And I've done exactly what patients have told me. And they're like, that's not it. And I'm like, all right,
Okay.
now show me. What is it? Oh, that's completely different from what you said.
Okay. Yeah, I guess I thought that uh in the past that there had been some talk about like you start away from the site of where they're directly having their pain if that's too sensitive for them because all the nerves connect to each other and then the tibial nerve is branching off of the sciatic nerve and that goes back to like the L4, L5 and everything. So I thought if you started away from the site of where they're feeling the pain, that's better when they're like in a more irritable state. Is that not that's not what you usually do?
That's not what I do,
Okay.
but I don't do what everybody does. So,
Okay.
but
Yeah,
what I
and
just
part of the
told you,
discussion, and I was going to say, part of the discussion that you probably heard was if there's a patient with CRPS or
Okay.
just a chronic condition, we typically don't want to flare that up, especially in the first
Okay.
exposure to Stimpod. So there's somebody that a lot of times will just start with vagal stim to calm them down. And then we can go to start treating some of the areas, but we don't want to go straight to an area and crank it up because that might really flare them up. I think that might be what you were hearing.
Okay. Okay. Yeah, or maybe this is, I don't remember where this was from, but we did also have like some sort of I think you had given some sort of talk to our clinic about it, and so maybe I misinterpreted something that was talked
Okay.
about at that. When you do start with it, after like if they have a good experience with the vagal stim, I mean, are you still starting distally with somebody who is in a more like highly irritable, more acute, or I don't even know if it's more acute, but more just irritable?
so like I'm well, if they're just irritable, like you could just put them in a room and let them do vagal stim and tell them to go home, you know. But um, I'm gonna go for what the real issue is. I'm not gonna like pussyfoot around. I'm just gonna go for it and then just try to help them
Okay.
immediately, give them relief. I expect people to
Okay.
leave feeling good, like on
Okay.
that
Even
first visit.
after just the first visit. Okay.
First visit, my intention is you're feeling better. Like you're gonna walk out of the clinic feeling better for
Okay.
sure, 100% of the time. And if I didn't do that, I'm going to spend the time till I did do it.
Okay.
And then, as busy as you are, if when you're done with your treatment for that patient, if there's the possibility to take 5 minutes or 10 minutes where it doesn't need you, but you get the patient set up with vagal stim,
Mm,
you can be doing paperwork, let them end their session with 5 or ideally 10 minutes of vagal stim.
okay.
That can be remarkable and that doesn't clog up. Again, I don't know the way the layout is in your clinic, but
Sure.
if
Sure.
that's a possibility, that could be really beneficial for them.
Okay. Okay. Thanks.
Yep. And I just sent you a link if you want to set up, get on my
Okay.
calendar. We can do a
Okay. Thanks.
one-on-one and you're welcome.
Okay. Thank you.
I have a question about the hearing loss lady. I've only been doing the tragus on the right ear. Would it be safe to do the Simbaconcha on the right ear?
Yeah. So it's so is she deaf in the right ear?
Yeah, it's significant loss in the right ear.
So it's tragus vagus, um, trigeminal, and mastoid is what I was
Mhm.
told. This is
Okay.
done by another PT who guarantees that it's like the best thing at all for tinnitus, and that's not my like. All I did was vagus and trigeminal, and then he put in the other ones.
Tragus and trigeminal on the right side even?
Yeah,
Or
yes.
okay.
Then he put in the mastoid, and he's a very smart guy, so I respect him. So if he knows
Mhm.
that it works for his patients, great.
Okay.
Um, I
Yeah,
don't
so I
get
just,
that much.
I just did tragus, mastoid, and, trigeminal, facial.
No, but
Kind of,
just do this. I wouldn't mess with this. I would just go
oh,
here.
here? Okay.
Yeah. So it's all around here. So it's vagus, tragus, trigeminal, and mastoid. So it's like everything is right there.
Okay. And should I just do the right side, or would there benefit to be doing the same thing on the left?
I would
Just,
just be doing the involved side.
okay. And then Ve
Um,
Vegas on the left. But
you could do Vegas on the left, but I would do the Vegas on the right also.
okay. Okay, thank you.
Is
Cool.
that good?
Anybody?
Is that good for tinnitus only or hearing loss and tinnitus?
I I I was told that's for tinnitus.
Okay.
Like I still don't believe it. Like there's a lot of different causes of tinnitus, and like like Angie, like I was saying, it's not going to hurt you. So like let's go and we'll just do it. It might work, it might not. I've had about 50% success in treating tinnitus, and the 50% are extremely happy. So I don't understand it. Um, and it is what it is, but it's not going to hurt them.
Cool. Anybody else? Last chance.
I have one last question. Would
Sure.
are you able to do this treatment or is it contraindicated if someone has cancer?
They say don't do it with cancer.
Okay.
Um, I would probably do it anyway.
Okay, yeah,
Yeah.
that wasn't on our list of contraindications, so that's why I was curious.
Yeah. I've seen active chemo treatment for cancer as the contraindication. Um, but again, the ability for somebody to do vagal stim, you can only imagine, the anxiety that they're going through and family members are going through. And so realistically, the ability to do vagal stim for people with anything, because similar contraindication that's always out there is pregnant women. Come on, you know what? Being able to help reduce their anxiety is indicated.
So not directly on their
Like my
pain, but just vagal stim.
No, so I mean, like my sister, I said this before. My sister had stage 2 throat cancer, and she had a ton of radiation. And I was like, I don't know if this is gonna work. She couldn't talk at all. She was like whispering. The next day, she goes and she called me up, and she's like, I'm feeling way better. We did it one more time, and she said, I feel better than I did before any of the radiation. And that was only 2 treatments, just doing vagal stim because vagus innervates the larynx where she had her cancer.
So
And that's
vagal
why,
stim is
Michelle,
what
I
you did
told
on her?
you, go
Okay.
do it to yourself. Watch. Do a little video of yourself just for shits and giggles. This is me before I couldn't talk. And watch. Half an hour after you do that, watch what happens. That's real. You can come back. Show us all what happens.
Was that just vagal stim that you did with her?
Yeah.
Okay.
Yep. So it's like I would treat anybody. Like I would love to have all post chemo and radiation patients. Give them to me 2 months after. I treated my sister next week, but um, I've treated people immediately after they got chemo, and it was bad. Like it didn't. It flared them up worse. So I'm telling you, just come back like 2 months after, and I'll treat it.
After they're done with all their chemo treatment, you mean?
Yeah, yeah,
Okay.
yep. Because the neuropathy and the pain is going to be there from that for a long time.
Yeah. Okay.
Cool. All right. Well, we will see all of you guys next week on Stimpod. Mary Jane, I'll call you because we're going to be in Seattle next week. So we'll go out for lunch one day.
Perfect. All right. Have
All
fun.
right,
Thank
guys.
you.
All right. See you guys.
Have a
Bye.
good weekend.
Bye-bye.
Bye.
Thank you. Bye.